Hello everyone, this is Dr. Prithpal Singh, an MD from CMC Ludhiana, and today I'll be talking about an important aspect of pharmacology, that is the pharmacological implications for special patient population. Now, when we talk about special patient population, we have the pediatric age group, the geriatric age group, the pregnant and lactating females. Now, these are considered to be to be the special population, and I'll be covering up these particular modules in 3 sessions. The first one, which I would be completing up, would be on pregnancy. The second one would be on pediatric, and the third one would be on geriatric population. Now, if you have any queries or questions to whatever I have been telling, you could easily get to me. You write down in the chat box, and I'll be happy to get back to you. Now, when we talk about the prescription of implication of special population, now that is where I would now highlight myself. Now, I told you I'll be highlighting to myself to the first concept, that is pregnancy. Now, as all of us know, that pregnancy is a period where it is said that almost all the drugs are contraindicated unless proved otherwise. Now, the pregnancy has been divided into three particular three particular zones. One is the first one is from day 0 to day 17, and then day 18 to day 55, and day 56 onwards. Now, this would depend upon the conception, the formation, organogenesis, and then growth of the organs. This is how it has been devised and divided. Now, whenever we try to give a drug, we have to be very sure which particular uh, time interval the drug is given, because any drug poses a significant risk to the pregnant female as well as to the fetus, because there are certain physiological changes in the pregnancy that tend to alter the way the drug is handled inside the body. So that is what we would be trying to talk about. Today we'll be talking about what are the various ways where we could use drugs in pregnancy. So whenever we are talking about the treatment goals of use of drug in pregnancy, what we need to do is we need to utilize the appropriate resources to determine the teratogenic risk and excretion in breast milk. Now, what we need to do is we have to always be very specific, and we have to always take care of the risk-benefit ratio of a particular pharmacotherapy. And whenever you want to start a treatment, what you need to do is you should start with a regime that is safe, effective, and minimizes the risk to fetus or infant. Plus, you should also minimize the drug exposure or to neonate or infant during lactation also. Now, this is one of the classical pictures of what a drug has done previously, and this is regarding thalidomide. It was animal studies found that this particular drug was a safe drug, and it was used as a sedative, and pregnant females obviously took it, and then all of a sudden there was a rise in cases of phocomelia, and the first case appeared in Germany in October 1957. Subsequently, many cases of phocomelia were found out, and then what was decided was it was risk-benefit analysis, and everything was performed, and thalidomide was implicated as one of the drugs that that was implicated to cause phocomelia, and this particular drug was banned or removed from the market. So this is one of the classical examples of what harm a drug can do if proper advice and proper cautions are not taken. Now, whenever we want to go for prescribing a drug in pregnancy, we need to categorize the drugs into 5 categories, that is A, B, C, D, and X. Let's start with category X, although I'll be going to each one of them as we come across them. But category X are, as the symbol denotes, drugs totally contraindicated in pregnancy. At no point of time, these particular drugs should be given in pregnancy. So first, now we come with what we can do is we can divide the category of the drugs based upon the animal studies and the human studies. So let's talk about category A drugs. So category A drugs show that there is adequate, well-controlled studies that have been conducted in pregnant women, and these studies have shown that there's no risk of fetal abnormalities, and these drugs can safely be given in pregnancy. Category B drugs are those drugs in which animal studies have revealed that there is no evidence of harm, but there are no adequate, well-controlled studies in pregnant women. This is one of the criterias, or the criteria could be animal studies have shown an adverse effect, but adequate and well-controlled studies in pregnant women have failed to demonstrate a risk to the fetus. Now we come to the category C. Category C says that there are animal studies that have shown an adverse effect, but there are no adequate or well-controlled studies in the pregnant woman, or animal studies have been conducted and there is no adequate and well-controlled studies in pregnant women. Category D is studies adequate, well-controlled, observational and pregnant have observed, demonstrated. These studies have demonstrated a risk to the fetus, and category C and category D drugs are only to be given if the benefit of therapy outweighs the potential risk to the fetus. Category X, as I told you earlier, studies have been conducted. These are well-controlled or observational studies which have been done in animal or pregnant women, and they have demonstrated a positive evidence of fetal abnormalities. The use of these drugs is contraindicated in women who are or may become pregnant, as we were talking about thalidomide in our thalidomide disaster case. Now, what is so special or what is so important? What happens in pregnancy that you need to take care of the drugs that are to be given? Now, what happens is there are physiological changes, and these physiological changes alter the pharmacokinetics of most of the drugs. What happens is, first of all, there's an increase in total body water, there's an increase in total body fat, there's an increase in GFR, plus there is a decrease in gastrointestinal motility and changes in absorption and gastric acidity. So if there's a decrease in gastric motility, that means drug stays in for a longer duration of time, and there is a possibility that more amount of drug gets absorbed. There is an increase in cardiac output, blood volume, and plasma protein. Now, these plasma proteins are significantly involved in binding of the drugs. So if there is a drug that significantly binds to a plasma protein that is produced in high concentration in pregnancy, so there is all possibility that there would be higher amount of this particular drug that is there, and there is decrease in the plasma and the concentration, so there could be a change in the bioavailability of drugs that are protein bound. So we need to keep these pharmacokinetic interactions or these key pharmacokinetic parameters in our mind before we start a drug. Then there's always a placental barrier. Placental barrier as such is an incomplete barrier, and there are various ways by which a drug or a molecule could be transferred to the placenta. The first one, simple diffusion. Obviously movement from a higher concentration to a lower concentration, but there are certain molecules that have a large size which may not permit the transfer of these molecules. And then we have active transport, where concentration of substances that are higher in fetus are transported back to the mother. Pinocytosis, where soluble molecules like viruses can cross membrane in small vehicles and are released. Facilitated diffusion, like glucose is rapidly transferred to the fetus, and there's a leakage. The fetal cells enter mother circulation through small membrane breaks. Now, these are the various methods by which either molecules or drugs or anything gets transferred or moves to and fro from the placenta to the maternal side and from the maternal to the placental side. So these are simple transport, simple diffusion, active transport, pinocytosis, facilitated diffusion, and leakage. Then all of it would depend upon the choices or the options that we have. So we need to choose very appropriately which particular drug has to be given. So I'll just give you a particular example. What happens is we should always try to choose those drugs that pass poorly into the placenta or the breast milk. And let's talk about one particular group such as benzodiazepines, which is a pregnancy category D or X drug. So obviously, if you have to give a benzodiazepine, you'll have to look into the trimester of the risk, whether it is the first trimester, second trimester, or third trimester. And flurazepam, temazepam, and triazolam belong to category X, whereas alprazolam is category D drug. So chlordiazepoxide appears to be the safest choice during pregnancy, but by no means I mean to say that chlordiazepoxide can be given. Obviously, what is more important is the risk benefit assessment. So whenever we try to give a drug in pregnancy, we have to measure the risk benefit, and only if the benefits outweigh the risk should a particular drug be given in pregnancy. Otherwise, that particular drug should not be given. And let's be on a safer side. We would say it would be more appropriate to say that all the drugs are contraindicated in pregnancy until proved safe otherwise, or all the drugs should be avoided in pregnancy unless proved safe otherwise. So this is all regarding the drugs that can be used in pregnancy. I hope I've been able to clear some concepts of the drug of the use of drug in pregnancy. And if you have any queries and questions, do get to me on my chat box. I'll definitely reply back to you. So till that time, wish you a happy learning and a great day ahead. Thank you so much for your patient hearing.